John. I come from Kerala, India, and actually did the study on tuberculosis in chronic kidney disease. I work now in Doha, Qatar as a fellow in infectious disease. Actually, the background of the study is that we had so many patients with tuberculosis. We had so many patients with kidney disease and unexplained fever, weight loss, and we evaluated them and found out that the possible etiology could be tuberculosis. And previous studies from India showed that the incidence was around 3% of tuberculosis in CKD, and now we wanted to do the profile of tuberculosis in CKD, and also more importantly the effectiveness of anti-tuberculosis treatment. It was a prospective study where we followed patients with tuberculosis and chronic kidney disease from August 2008 to July 2010, and this is the dosing of the drugs, various drugs that we use in these patients, and we gave them INH, rifampicin in a daily dosage, and since the other nephrotoxic drugs like pyrazinamide and ethambutol were given on alternate days, like every other day, so the patient usually get 3 doses per week, and the dosages were the same, but actually we did not decrease the dosages, we actually increased the dosage interval. And cure, we call it cure if the patient had clinical with radiological or microbiological or lab evidence of improvement. Actually we gave them, for the severe types, the duration of treatment was almost 1 year for patients with severe form of tuberculosis, and for patients with less severe tuberculosis it was mainly we gave them 9 to 6 to 12 months of treatment depending on the site of affection. And the results of the study were the incidence were high compared to the previous incidence of 2.5 to 3%. It was almost 5.77%, and we had out of the 572 patients with chronic kidney disease, 33 had tuberculosis, and mean age was around 46.5, and extrapulmonary tuberculosis was the predominant form, with TB pleural effusion being the commonest, followed by the CNS forms of tuberculosis. And the cure, with giving this treatment, the cure was almost 84.8%. Out of the 33%, 33 patients, 28 had cure, the clinical improvement along with radiological or microbiological important. Actually, this chart is a bit wrong. It is 28. The number is 28. It's not percentage. Okay, the outcome cured, and 3 patients had death from tuberculosis. That was mainly in patients with disseminated forms of tuberculosis and CNS tuberculosis. And the complications, the other important aspect, ATT-induced complications, the commonest one was gastritis, followed by drug-induced hepatitis, and 1 patient had INH psychosis, and only 1 patient had the worsening of his prior renal function. So the results of the study was not previously considered. The response to ATT is quite good in patients with chronic renal failure. Regarding the treatment, you should not decrease the dosage. Actually, you should increase the dosage interval for nephrotoxic drugs like pyrazinamide, and there is no need for second-line drugs. You can manage with the first-line anti-tuberculosis drugs, and worsening of renal function was seen only in a few patients, establishing the fact that ATT is quite safe in chronic renal failure patients.